50% of people that die of heart disease never make it to the emergency room because they have a heart attack that's sudden, unexpected, and fatal. That's the population that we really have to focus on and really identify. Lab tests are good, but they're an indicator, but they're not ideal because there's a lot of people that will fly under the radar. Either the lab tests may not be significantly off and they may think that things are okay and they've not really treated it, or they may have completely normal labs and still have a plaque that's been developing. And this is where screening technologies come in that are much more advanced now than we've ever had before.
What happens to cardiovascular risk and cholesterol metabolism, and maybe generally any other heart markers as women move through menopause? Because it's not only me, but many women I meet who are like, we had perfect cholesterol and suddenly the doctor wants to put us on statins. It's like in a day. What's going on?
Yeah. Women are very dependent on their hormonal health. Women have a complex milieu of multiple hormones, and they often go higher. Estradiol, progesterone specifically, you will run higher than men. Estradiol, progesterone, and testosterone all play an interconnected role in vascular health. In men, it's mostly testosterone with some estradiol. In women, because there's fluctuations and because there's such a high amount of that estradiol and progesterone, you have a much greater dependency on that for your vascular health.
Well, it's a real pleasure to have Dr. Abid Husain on the show today. Welcome.
Thank you, Zora. I'm really excited to be here.
I'm excited to talk about heart health. And as you know, you are helping me sort out my cardiovascular markers and my heart health. And whenever I have a problem that I need to really deep dive into and I want to see somebody, I want to see an expert, I go to Boulder Longevity. I think everybody knows that. And you guys are a seriously good team. And I have some wonky, weirdo stuff going on with me in terms of some things are great and some things are really not good. So I don't understand it when people like me, I'm just saying this, whoever's like me is doing all the right things, walking the talk. But yet, why aren't your markers perfect? Perfect in what we understand perfect. Yeah. I'm concerned about heart disease because it is the #1 killer for both men and women globally. And as we're going through menopause, our risk for cardiovascular disease increases so much. Just what happened here? Everything was fine until I hit menopause. So why don't you tell us first, why is heart disease still the leading killer here, and explain what that someone maybe means when they talk about heart disease?
Yeah, there's many reasons why it's still the #1 killer globally. And I think first, let's start with our understanding of what heart disease is. Heart disease is many things. It's not just one thing. It is atherosclerosis, hypertension, arrhythmias, heart failure, and everybody has a different susceptibility to these things. And these are all slow-moving processes. So when we talk about heart disease, classically, it's blockages of the arteries, atherosclerosis, because that really is what kills people. That's the sudden event that everybody's afraid of. So let's zero in on atherosclerosis. Atherosclerosis is a slow, silent process. It's a slow disease, and it takes decades for it to really manifest. So, and it doesn't really show up as a symptom until 70% of the disease is present. So you can have 50% of the disease and not know it. And oftentimes you can have 50% of the disease and then have a sudden event where 50% plaque ruptures and that causes a heart attack. But you might just be moving along completely unaware of what's going on and have these risks. The mindset of having a symptom is now when you have heart disease. And that's not the case. Heart disease starts happening decades before, and that's why we've got to start looking for it decades before. If we wait till the symptoms are there, then it's already too late, because that's like imagining you can move a cargo ship when it's empty is very nimble and it can move quickly. That's like when you're young. When it's loaded with luggage, with cargo, as we get older, it takes a lot, it's got a lot of momentum, and it takes a lot of effort to move that. So that's what happens when you have a 70% blockage or more. You've got decades of momentum that won't stop automatically. And just because you might have done some lifestyle changes or started some medication a few years ago, it might not be enough. You might still have a lot more momentum driving it forward. Conceptually, we have to really reconceptualize what we believe as heart disease. We're addressing it too late. We're starting too late, and the damage is already done by that time. That, and then we've relied on single marker belief. We think that cholesterol is the only thing that indicates heart disease. That's a 75-year-old thinking. We know that cholesterol is part of the picture, but it is a very complex problem. It's layered, and thinking that one biomarker is going to determine whether you have a risk or not is really not looking deeply, and it's not taking advantage of what we've learned over those 70 years.
So you said, so when you talk about atherosclerosis, this is really, and it's a silent killer. Like, you don't feel your arteries getting clogged up. This is the problem, and this is what frightens many people. I do remember taking a class in gerontology all about cardiovascular disease, and they said the impression that I had come out with that was, oh, everyone eventually will have some percentage of clogged arteries. I almost felt like, oh, there's nothing you can do about it. I guess some people worse, some people less. Is that true? And what could we do to slow the progression, which will be probably another question down the road?
Well, yeah, there is some truth to that. And part of the belief, part of the thinking was how we were treating it. If we didn't have any ways to slow down heart disease or atherosclerosis, if we didn't know what the true pathophysiology is, and we just thought it was one thing, and we only had very limited tools, well, then the thinking, okay, we don't have much we can do about it. This is what we consider normal. And yes, most people as we age will develop some plaque. The question is, when did it start? What are the processes that develop it? And how can we slow it down? We didn't have ways to do that before. In the current era, we have a multitude of ways to do that as it's happening if we detect early. You have to understand that cardiology, especially in the United States, is mostly a end of spectrum treatment specialty. There are stents, there are surgeries, there are procedures, all of that is done after you've got more than 70% of disease, after you showed up with some sort of a symptom, when it's life-threatening. We are really good at doing that. But there's very little that's looked at the other end of the spectrum where it's slowly developing. And that's where we can really make change. And that's where we have to look, because those are slow moving targets, and we can look at multiple different biomarkers very subtly and see how things are changing along the way and correct them early. So yes, people develop plaque. It's something that a lot of people have. Is it part of normal aging? I would beg to differ.
Yeah, that's what the question I always have whenever I see somebody about my cardiovascular markers. I'm like, I don't care about a number. I just want to know, am I going to have a heart attack? What's my risk? And we hear these stories, these horror stories of somebody's perfectly healthy. They were out for a jog and then they fall flat in their face with a heart attack. And that's, I think, what's fearful, because that's the silence of it all, right?
Yeah. Yeah. That's the largest sector, the largest population that gets heart disease. 50% of people that die of heart disease never make it to the emergency room because they have a heart attack that's sudden, unexpected, and fatal. Yeah. That's the population that we really have to focus on and really identify. And lab tests are good, but they're an indicator, but they're not ideal, because there's a lot of people that will fly under the radar. Either the lab tests may not be significantly off, and they may think that things are okay and they've not really treated it, or they may have completely normal labs and still have plaque that's been developing. And this is where screening technologies come in that are much more advanced now than we've ever had before.
Yeah, we're gonna dive into that. But before we do, I want to understand what happens to cardiovascular risk and cholesterol metabolism, and maybe generally any other heart markers, as women move through menopause, because it's not only me, but many women I meet who are like, we had perfect cholesterol and suddenly the doctor wants to put us on statins. It's like in a day. What's going on?
Yeah. Women are very dependent on their hormonal health. Okay. Women have a complex milieu of multiple hormones, and they often go higher Estradiol, progesterone specifically, you will run higher than men. Estradiol, progesterone, and testosterone all play an interconnected role in vascular health. In men, it's mostly testosterone with some estradiol. In women, because there's fluctuations and because there's such a high amount of that estradiol and progesterone, you have a much greater dependency on that for your vascular health. Estradiol and progesterone do have a different interaction in different sized arteries, and because of that dependence, when your hormones start to decrease in production, when you start to hit your perimenopausal years and then into menopause, you lose the protection and from that estradiol and progesterone. Women have a dependence on that. And so the loss of those hormones create a cascade of metabolic problems and vascular problems that then increase your cardiac risk to the point that after about 10 years post-menopause, you have the same risk about as age-matched men.
Yeah, it's crazy.
Yeah, and then you end up getting different diseases too.
So you mentioned, I heard you in some other podcast talk about nitric oxide as a key marker. I'd like to know how estrogen and, I don't know if progesterone and testosterone affect the nitric oxide and then vascular health in women in general.
So nitric oxide is a nexus point for a lot of different things, a lot of different pathways. And it is one of the compounds, I mean, it's a gas, really, and it's a gas that is made in our lining of our arteries. And it's the nexus point or convergence point of different upstream systems. It could be glucose regulation, it could be mitochondrial, it could be from the liver, and it could be hormonal. They converge, and nitric oxide is one of those central points where that's how those systems regulate vascular health, inflammation, even mitochondrial health. And so when we lose that, and it could be from any one of those systems, then you lose the ability for the endothelium or that lining of the artery to buffer inflammation. It loses the ability of the muscle cells in the arteries to dilate, to open up and be flexible. It loses the ability of your insulin regulation and maybe, your muscles to be able to function more effectively. So we lose the ability to relax. And so, nitric oxide is that central point. And then when that bottleneck happens and it's not working appropriately at that enzyme, then it creates other problems after that, meaning more inflammation, inability to be resilient, hypertension, inability for the arteries to be flexible, inability to control cholesterol, LDLs specifically. If LDLs when they get inflamed, we have the ability to reduce that inflammation via nitric oxide. And when we lose the ability to make that, normal insults that might cause LDLs to become a little more inflamed then become amplified. When we look at specifically at hormones, men and women have a higher dependence on estradiol. Estradiol improves that nitric oxide, and when you lose the estradiol, you lose one of your foundational abilities to make that compound. Now, there is some dependence on testosterone, but because women have a lower baseline testosterone and less fluctuation, you don't rely on testosterone as much for your physiology. It's important, but it doesn't have the same importance as estradiol and even progesterone.
So we know there's so many things that happen when we're aging. We lose our hormones, or we have less melatonin, less NAD, less everything, name it. And then somebody's got a supplement for it. So or some way to put it back in. So is nitric oxide the same? Like it's just part of aging, or are there people who are living long, healthy lives and still have plenty of nitric oxide naturally in their system?
Nitric oxide decreases. It decreases with aging, but it's a secondary effect from other systems that are more sensitive to aging. When we age, we lose efficiency of our mitochondria. We build up reactive oxygen species. The mitochondria become less efficient. We make less hormones. So we have less of a ability to be resilient when stressed, and the ability to make antioxidant compounds. Those things that we rely on to maintain our regenerative ability, when we lose those with aging, those trickle down to affect that nitric oxide. So nitric oxide does reduce, the ability to make it reduces. It's that, there's an enzyme, it's called endothelial nitric oxide synthase. And so short for eNOS. And that's the enzyme that's critical in making it. All of those things that I talked about, they affect eNOS. So when we do age, yes, it does reduce, but it's not directly because of aging. It's usually other upstream things that affect that enzyme.
So there's things that we can't control is our loss, at least women, at least the loss of their hormones, and mostly about estradiol and the estrogens and progesterone. But there are things that don't have to be aging, like bone loss or muscle loss. Like we see plenty of people who, okay, we can do something and we can maintain it, but no matter how healthy we are, we're going to go through menopause. We're going to lose those hormones, which is really frustrating because they're like, oh,
it is.
You can't.
Yeah, some of that is programmed. It's very frustrating.
Yes. So when it comes to nitric oxide, I'm still trying to understand, is that it's because of, you said there was some other things that really, if the hormones are gone, okay, nothing we can do about it. But men seem to be holding on to testosterone a little bit better than the women are. Are they having better nitric oxide numbers than women? Does it depend on how much testosterone they have left or whatever else is upstream?
Yeah. This goes back to your question about why suddenly things just start to collapse at menopause for women. Women have a higher dependence of estradiol to make these compounds like nitric oxide. And when you have a sudden loss of estrogen in years quickly, you're going to notice that very significantly. Men have a more gradual loss of testosterone, and it can happen over decades. The loss of testosterone does impact men's ability to make nitric oxide as well. And that more gradual loss is often underappreciated, and that can impact vascular inflammation. And that may be one of the reasons why men tend to have earlier disease and more heart disease, because it's an undetected loss. It's a contributor. There's many other things that contribute to it. The men tend to have more heart attacks, more atherosclerosis until the equivalent age of menopause. And then women catch up after that, because then they have this sudden drop. And now all of a sudden they've lost the hormone that they were more dependent on.
Just so people understand nitric oxide, because it sounds like, wow, this is really cool. This is maybe something we need. I understand it as it's a vasodilator. It brings blood flow, and then we have more blood flow. We have more nutrients going to the cells, and it helps us regenerate and whatever. There's probably a billion other things that nitric oxide does, but I'm always thinking blood flow, better sex, better performance in the gym, better whatever. We need blood flow. So what is the best way to improve our nitric oxide llevels?
Best way
of a woman in menopause. I'm sorry with the guys right now. Well, let's focus on the women.
So for women, that's one of the reasons why I am a firm believer in hormone replacement therapy. Put back the hormone that you've lost, that is essential for one of the essential ways of helping to make nitric oxide. So give that hormone replacement back to women. So this way your vascular system can remain more flexible. It can have anti-inflammatory capacity. It also affects the LDLs and HDLs. When you lose estradiol, those LDLs tend to become more atherosclerotic or more oxidized to cause atherosclerosis. The HDLs will reduce. Replacing your estradiol improves your HDL. So it improves vascular inflammation as well as blood flow. Progesterone is also important for that too. Progesterone, when it drops, it's associated with what are called vasomotor symptoms. And those are symptoms where the arteries tend to spasm a little bit. And that loss of blood flow causes hot flashes, causes night sweats. So the treatment for that is to replace the progesterone. That often happens gradually in years before you start to get to actual menopause. In those perimenopausal years, a woman may not even realize that their progesterone is decreasing. And this is why we often test everybody once you get past 30 years old. It can sometimes precede menopause by 5 years or more.
Yeah, HRT is quite powerful when it comes to heart health. There's research showing that I tell women not to ignore their hot flashes or night sweats, because there's an association with higher risk of heart attacks and all kinds of cardiovascular events. So it's kind of like, oh, it's not that big of a deal. I'll just kind of push through it. Well, no, not really. I think it's really important. And I think you've tied it in. It does so much for your heart health. It helps with the nitric oxide and many other things. But I've also heard, I don't know how true this is, and I know it's a brain question, but brain and heart very often go together.
They are.
There's this viral idea that hot flashes are like, quote unquote, mini heart attacks in the brain. Yeah. Is that true, exaggerated, or just a wrong metaphor?
You could say it's a little bit of a stretch, but there's some hard science behind it. When they look at women with hot flashes and having vasomotor symptoms, looking at brain scans, I think they were MRIs, they showed that there were higher incidence of microvascular damage or microvascular insult. That's where the vasomotor symptoms happen. It's not the larger arteries. It's in the smaller microvascular arteries. And when they spasm, they will create lack of blood flow, create inflammation, and what are called microinfarcts, or the appearance of mini strokes. Women with higher symptoms of hot flashes tend to have more of those. A mini stroke is a serious thing. These mini infarcts reduce brain matter, and this is what we see that leads to dementia. So this puts them at a higher risk for that. Having hot flashes and night sweats is not a benign thing. It's something to be taken seriously, and it's not something you should suffer through. You want to treat that, especially if you value your brain health.
Yeah, there you go. That's exactly great. It's interesting to hear that because they are, I've seen them, these scans are like micro lesions or something. Yeah. You see it on a scan, which is incredible. And maybe there needs to be more research and all that stuff, but I'm like, I'm not going to wait just until that comes out.
Again, it comes back to that belief like, okay, we see these things that happen in older people. We haven't put together why they're happening or what the associations are. And we're starting to do that now. And it all points to earlier diagnosis. It all points to earlier detection and earlier treatment. Don't wait till it's symptomatic. Wait to see if you can detect it early and then anticipate it.
Great. Since we're talking about little heart attacks and mini strokes and things, I want to go back a little bit to the symptoms of a heart attack for a woman. Yeah. I understand are different and they look different than a man's. So what should a woman really be looking out for?
Yeah, the symptoms for women are also, because the way heart disease tends to manifest is more diverse. Women have a tendency to get more microvascular disease as well. So that often shows up with different symptoms. And that can be, certainly you'll have chest discomfort, but it can be different types of chest discomfort. So if you think about it, what happens is when you look at a microvascular situation, you're looking at blood flow to larger areas, maybe the entire heart. So it ends up showing up as more vague symptoms sometimes. It could be shortness of breath. It could be a feeling of some types of chest pressure. It could be a fatigue. It will also show up as nausea because sometimes certain arteries have a higher tendency to be more represented or more involved in women. So the symptomatology is very different. It can be very vague. It could even end up showing up as right-sided symptoms, where classically it's left-sided for men. So anything that involves those areas of the upper part of the chest. And this is why so many women have been misdiagnosed with anxiety, because the symptoms were just not fitting into these classic symptom patterns. This is one of the historic injustices done to women. They've just not been studied and appreciated as different people, different beings that have different symptomatology.
So shortness of breath, chest pressure, fatigue, nausea, right side symptoms when it should be classically left. Yeah. I've also heard indigestion and heartburn, back pain.
Yes. Definitely, yeah. Indigestion, yes. Because the artery that can sometimes feed the lower part of the heart is the abdomen, and is right above the abdomen. And that can influence a little bit of nausea. It can influence the diaphragm and then stimulate that.
Crazy. It's really sad. I've heard these stories of women literally going into the emergency room with heart attacks, but they've just said, oh, it's a little bit of indigestion and just go home, and then they go have their heart attack. It's just terrible. So I think we want to bring a little bit more awareness to that. But if a woman is at home, let's say, and she feels like, oh my God, I'm having some of these pain, and maybe she's a smoker, maybe he's overweight, maybe it's clearly, oh, I think I really am having a heart attack. And I'm totally being stereotypical. So stop me and correct me if I'm wrong. But is there anything that she can do to increase her chance of survival while she's sort of waiting for 911 or getting herself to the hospital? Like any little tip?
We know that aspirin is something that most people have at home. Having an aspirin, and there's some belief that chewing it and swallowing it will increase the absorption, but getting something to thin the blood a little bit is going to help. So a full dose of aspirin, and that's usually about 325 milligrams. That's important for an immediate medication or something like that. Outside of that, there's not too much you're going to have at home that you can do. So then what you want to do is you want to stay calm. You want to make sure that you're not doing anything to increase your heart's work demand. So sometimes, and you also potentially you just want to lay down too. You want to wait for EMS to be there. Definitely don't drive yourself to the hospital because for many reasons you may lose consciousness, you may become lightheaded. That complicates the situation, especially while driving. As I was mentioning, there's one artery, the right coronary artery, that feeds the lower part of the heart and the underside of the heart. That is very influenced by volume. And so sometimes and that's more often involved in women, sometimes the blood pressure will go down. So staying flat and supine is important so that you maintain blood flow. And then try not to get too excited. Take deep breaths to maintain oxygenation, and then try and keep the heart rate controlled.
The breath work. I can see people's eyes rolling like, oh yeah, breath. Mm-hmm. How do you control the breath and stay calm when you're having a heart attack?
Yeah.
But I did the breath work training with Oxygen Advantage, and it's just about functional breathing. And what I've noticed over the years is that I try to encourage women to please just practice every day. Just do it every day, even if it's just a minute, because the time that you need it, you will not remember what I just taught you. And there's different techniques and things like that. But I think it's so powerful. The breath can control so many physiological responses. And we have it in our hands. It's free. And I'm just on my high horse now, just like trying to get everyone to learn how to breathe, and especially the techniques that may just save your life. Yeah. I want to go to talk a little bit more about the detection of heart disease and any cardiovascular information that we need to know. What can we do globally to detect it better?
The detection, I think it's going to start with identifying the at-risk population. And one of the things is blood tests. We do want to screen people with the right blood tests. That does indicate what's going on metabolically and what treatments might be useful, what might be the root cause for the atherosclerosis. If it's blood sugar abnormalities that haven't been detected, maybe it's in some sort of other sort of inflammatory disease. But I think that one of the main the screening tools is imaging of the heart. This has become this tool has really become much more precise and advanced over the past 3 to 5 years. About 5 years ago, the technology for CAT scans really got caught up to speed for it to be able to accurately take pictures of the coronary anatomy. And it couldn't do it before because the heart's always moving. And it moves so much that it made pictures blurry. So the scanners weren't really up to speed. There were only a few of them that could take pictures of the heart accurately at that, even though it would be moving constantly. About 5 years ago, we realized, okay, if we slow the heart rate down just a little bit, and the scanners are now strong enough and can take a more precise slices, we can now take good enough pictures that we can really look at the coronary arteries. We can see the degree of blockage, and what's more importantly, we can see what's inside the wall. And that's really what the main information that we want to see that we're getting now. Then probably right around 5 years ago, the machine learning started being implemented, because what was being realized was that you could take these high quality CT scanning images and look at them pixel by pixel and really determine what's going on in the arterial anatomy. That process used to take hours, 6 hours for one scan to be done. With machine learning, that's an automated process, and now we can look at those scans in minutes and be able to process a CT scan to be able to see what's going on in the arterial anatomy. And that screening tool has really opened up our detection abilities and to look at specifically what the composition of those arteries are. If it's got calcium, if it's got cholesterol, or if it's got really inflamed high-risk cholesterol.
Okay, wait. We have the standard blood tests that people take, and
Yes.
it's not enough information. Clear. But you're saying if we get some screening, diagnostics, or some kind of way to look inside the heart, then that gives us a better idea of how clogged are your arteries or what's in there. So you said there's CT scans, or is it the same as the CAT scans?
Yeah, CAT scans. That's right. This is a CAT scan with contrast. So classically, what's been done is what's called a calcium score.
Yeah.
Now, that is a CAT scan, but it doesn't use contrast. And so when you don't use contrast, you mostly just pick up bone and a little bit of tissue. Now, a calcium score, because it's picking up calcium, that's the part of the bone that it detects. When you're looking at it in an artery, it'll pick up little nuggets or grains of calcium that are developing in the artery. When you look at how plaque develops, calcium is what happens at the end of the spectrum. It's what happens after disease has been present for a long time and the body has had to figure out how to stabilize it. So that's the second half of disease, of plaque formation. The whole first half, where where cholesterol or LDLs start to deposit, and then the LDLs may get inflamed, all of that is completely missed because it doesn't have any calcium. So a calcium score will only detect what's at the latter end or the late stages of plaque. Right? That's what was used for many years. And so if somebody has a lot of calcium, then we know they have a lot of disease. That's an easy association, and that's a high-risk person. But if they don't have a lot of calcium, they could still have a lot of plaque that's non-calcified or made of cholesterol. And that person gets missed. And that's the person that's at a higher risk for a sudden heart attack. Because the soft plaque is usually what bursts and is metabolically active. The calcified plaque is not. So you can miss those people that are at high risk. So the advantage of using contrast is we get to really differentiate what's in the artery and then what's the fat, the cholesterol, and what's the calcium. And so by looking at that, we can really see what specifically is going on in the plaque and isolate what is that cholesterol now. And now we can identify those people that are at much higher risk. And taking that further, we can subdivide that cholesterol part of the plaque into a highly inflamed portion or a non-inflamed portion. And so when people have that highly inflamed portion and lots of it, then that isolates a really high-risk individual. And that's the person that might drop dead from a heart attack unexpectedly.
Okay, CT scans and the calcium score. And
Yeah.
So there's two different kinds. There's the one with contrast, one without. And you're saying
Yes.
the one with contrast gives more information.
Yeah.
And that's probably because I was so close to get a CT scan until I read somewhere that the calcium scores can be 0 and you're still full of plaque. So I was like, oh, why am I going to even waste this money on this? So I didn't do it. But what you're saying is that because those are not done with contrast, and you're saying, but if you do with the contrast, it's more accurate?
Yes. The contrast is one aspect of it, and the CAT scan with contrast is usually a higher quality scanner too. Just to detect calcium doesn't take a very sensitive scanner, and it can do it quickly, and it doesn't need a lot of detail. To detect plaque and using contrast is usually done with a higher quality scanner, and that higher quality scanner is what will give us all those details, but it needs contrast. The differentiating factor is often usually whether they're using contrast or not.
I see. And so the one with contrast also detects if it's soft plaque or hard plaque. And it's the calcified ones that are, quote unquote, a little bit more safe than the soft one that can break off and then cause a stroke or a heart attack. Is that correct?
Yes. Yeah. And so that's a very good point. It's not just that they're using contrast. It should be a very high quality scanner too. And oftentimes when we're looking at a scanner or getting a CT with contrast for your heart, then they will have one of the higher quality scanners that's doing that.
Is that so? Yeah, somebody who's listening now goes, "Oh, okay. I'm in the US. Let's assume that
Yeah.
they're there because we have a whole audience who are not like me.
hmm
But let's say they go and they find, okay, they've located a clinic or they found a place or they go to Board of Longevity. They
hmm
could they just assume that the scan, if they say, "Oh, I want a CT scan," do you have a CT scan with contrast? Yes, we do. Do they need to ask any other questions to make sure
Yeah.
it's the higher quality machine, or what else should they know about it?
You really just need to ask if it's specific for the heart and for the arteries of the heart.
Okay.
Do you have, if they ask if they do a CAT scan with contrast for the heart to look for plaque in my arteries, that will usually tell them that'll usually be the right question to ask.
I'm wondering also if these CT scans, they tell if there's plaque in the arteries, but all the arteries in all the body, or just the ones closest to the heart? How good of a picture do they give you of the
Yeah.
whole body system?
This is specific to the heart, and it's keeping the imaging to a small window. It can be applied to the rest of the body, but you can use other imaging techniques to do that because the other arteries in the body aren't moving as fast. So it doesn't require as much of a high precision scanner. And going back to this idea, this CAT scan with contrast, what we do now is take that image, send it to companies now that are AI-based platforms those are the ones that are processing these images. They're processing these volumes of pixels and giving us really detailed information about severity of stenosis or blockage, the composition of those arteries. That's where we're getting a lot of that really specific, detailed, and very helpful information. So it's a two-phase thing. The companies that are in the States now are Clearly, so that's Cleerly. There is another company that's rolling out in the United States called Caristo, and they have something called Carry Heart. HeartFlow is another one. So there's multiple companies that do this in the States, and that's one of the other questions you can ask. Mm-hmm. Can I have my CAT scan interpreted by Clearly or HeartFlow? And then they also have specific quality control, and will work with centers that are only using higher quality scanners.
Okay. This is something I'm planning on doing, as you know,
Yeah.
but not whoever's listening doesn't know, but I'm going to be doing one. I'm looking for in Europe, and it seems as though we can find a Carry Heart in the UK. I'm still on the hunt if there's anything in Portugal or Spain or France or Germany or wherever it is, but I think it's a really important diagnostic tool because it seems that's the gold standard in that sense that you could really see a lot of stuff. But if somebody has a CT scan, and just so people understand, because I didn't understand this, I'm assuming if you're listening to this now, maybe you didn't either. I wasn't sure if I had to actually literally go into a physical building that has some kind of scan for this Clearly scan or Carry Heart. But as I understand, it is you get your CT scan first, and then that gets interpreted. And it's data. It's a machine that must filter through all of the CT scan. However, you explained to me before we even started recording that you can actually go into a center that does both and gets it all done in one spot, right?
Yes. The CT scan collects the data. Those other companies that I mentioned process it. So when you get a scan done at a center, it's going to be interpreted usually by a radiologist. And then, so they'll have their own interpretation. And then that we now have the option of taking that data and then getting it further interpreted.
Yeah. So it's a dual action process. You got to pay for the CT scan, then you go pay for the Clearly or the Carry Heart, whatever it is, two different things. If somebody has a CT scan and their calcium score is 0, do they need to move on to the next, or is it that just extra information not to be too concerned, or what should they do?
It depends on when that calcium score was done and what their risk factors are. I often get patients that have some sort of old calcium score and it was 0, but they have risk factors and their numbers may have some elevations. I will get a further CAT scan with Clearly or Carry Heart on them. if the calcium score was a few years back, then you could get another calcium score if finances are an issue. And then you can compare the progression. If the calcium score is the new one is still 0, then that's a pretty good indicator that they didn't have soft plaque in the past. But if the calcium score has now become positive or it's more positive than expected, then that means they did have soft plaque in the past and they've developed calcium now. And so there was something that was undetected in the past and they probably need a further test. They probably need to get something to look into it.
So does the CT scan or the clearly look at the percentage of blockage in arteries?
Yes. Yeah, it is a really precise assessment of what's going on. It'll give a precise amount of blockage of the artery down to the percent. It will also give a measurement of cubic millimeters of the amount of calcium, the amount of cholesterol, and the amount of inflamed cholesterol. So these are really useful markers that we can track because we're looking at down to less than 1 cubic millimeter. And as we track that over time, these are definitive, objective markers to look at whether plaque is reversing, whether it's staying the same, whether it's getting worse, and the composition. Because it's not just about trying to remove it. We're also trying to convert what's been inflamed and you may end up seeing more calcium. And that's okay because calcium is stable. We've gotten rid of the dangerous parts of the plaque.
Okay. So just to give people an idea too, so you get your CT scan. I don't know how much these things cost, but I know that the Carry Heart is somewhere around $700.
Yeah.
And I'm assuming insurance doesn't pay for it, maybe not.
They will pay for it if you have shortness of breath or chest pain. It's FDA approved for reimbursement now. So that's where the challenge is. If you don't have symptoms, insurance won't pay for it. But if you have symptoms, insurance will pay for the CT scan and the AI processing.
Oh, cool. Oh, very interesting. And the CT scan, the contrast dye, it's not gadolinium, it's something else.
That's right. It's iodine based, so we have to be careful. That's filtered by the kidneys, so we have to be careful with kidney function. Oftentimes you'll want a blood test to measure basic kidney function, and it will, if you have chronic kidney disease, definitely something to be aware of and maybe a limiting factor. But if you don't have chronic kidney disease, most people tolerate a small amount of contrast very well, and you just need to hydrate a lot the day before.
Okay, because the gadolinium, I understand people who have kidney issues that have to be very careful, whatever, if they're getting an MRI for whatever. And I do have a protocol, Dr. Yorth, on how to prepare to clear the gadolinium, but I'm assuming maybe it's probably similar protocol we could use for iodine with this.
Yeah, it is a little different because gadolinium is metabolized a little bit differently. So with iodine contrast, it's sometimes bicarbonate's used, but it also depends on the individual because if you have heart failure, bicarbonate can make you retain water. There's a lot of fluid, and then kidney protecting agents that are going to be similar.
Okay. All right. I also want to give people a little picture of a CT scan as well. If you go in there, you're getting injected something kind of like an MRI with gadolinium. You go under like on a bed and there's something going over your head. Give us a little visual. What is a CT scan like?
A CT scanner, a CAT scanner is much easier than an MRI. It's not the long tube that you got to get into. It's usually a much more narrow device. It's like a donut instead of going into a coffin and it's not quite as loud. The banging that happens with the magnets in a MRI does not happen. You're on a bed and it will slide in and out of a relatively small donut-like structure.
Okay. Is there a radiation with that?
Yes, it is. It's X-ray based radiation. In the right hands, the CAT scanner doing imaging of the heart is probably equivalent to about 2 to 3 mammograms.
Oh.
So there is radiation. It's X-ray based. In the big scheme of things, it's not that high because you will get more radiation if you're flying once a month if you're in the airplane once a month for long flights. So yes, to be aware of, but not a major concern.
Okay, yeah, I've got a radiation offset protocol for people like me who
Hmm.
travel all the time, always in a plane, getting
Yeah.
mammograms, doing the scans, doing like I do it all. So it's like I need all the help I can get.
Yeah.
So we can have offset some of this damage as well because sometimes the benefits definitely outweigh the risks. And I want to get one of these scans, so I'm definitely going to do it. I wanted to ask, when do you
Right.
think someone should start screening for heart disease?
This is a great way to get back to what we talked about originally. The heart disease is a slow moving target and it builds steadily, progressively, and it's relentless, especially atherosclerosis. So we need to see what's starting to cause this early on. I think everybody should be screened much earlier than we are doing right now. Some traditional screening says maybe start at around our 40s, maybe 50s. I think it should be done earlier.
Mm-hmm.
At the latest, by your 30s. We want to see if you have genetic risk. Ideally, if you have family history of heart disease, then do it in your 20s, because there are specific markers that we want to look at that are easily detectable now with just a blood test to see if you have an increased genetic risk. And then that means we've got to change your lifestyle. We've got to start doing things earlier on. And then the earlier the better. If we detect it early, then we can move that ship more quickly and get you and keep an eye on whether plaque is developing or not. Keep an eye on the metabolic changes that would be silent and wouldn't be diagnosed far earlier if we didn't look sooner. So yeah, I think late 20s, early 30s, late 20s if you have a genetic risk. You could probably push it to 30s, early 30s if you think that if there's no genetic risk, but it's still important to look.
I like that answer. I got 20-year-olds and I want to
Yeah.
see those beautiful scans, hopefully, beautiful blood work while they're young and we know what their baseline is. And
Yeah.
if it isn't beautiful, like you said, the earlier we change certain things in our life, then the better chance they have when they're older. And like you said,
Yeah.
there may be some genetic mutations or family history. And
Hmm.
I agree with you. I'm totally on board of just getting all their screenings and blood work and all that done. And
Hmm.
it's not like they have, I mean, unless they had something you need to take a deeper dive in, but just assuming a younger person is clean or good or whatever it is,
Yeah.
they don't need to do these screenings every year, right?
No, definitely not. If things look healthy and you've got imaging and there's no plaque, then you probably got 3 to 5 years to repeat it, at least the imaging. And blood work is very easy to do. You can do that annually, and that's not these days. It's not a big expense, and it's also subtle markers that don't. There's no radiation. There's no other real outward cost except for the cost of the test and a little blood. So I think there's plenty of ways to track health early on that don't require exposure to radiation.
So if somebody wants to look at their blood work as a
Hmm.
starting point before they dive into the CT scans and the clearlies and all that,
Yeah.
you gave me a long list of things to do.
Yeah.
I appreciate that so much because the first time I was told about my high cholesterol, my
Hmm.
doctor looked at me and he did just the total LDL, HDL, probably
Yeah.
triglycerides, and he goes, "Oh my, I based on your blood work, I need to give you statins, but I
Hmm.
know you, so it feels so wrong." Like he wasn't up to it. He
Yeah.
didn't know what was going on. I was like, "Am I going to have a heart attack? What are you talking about? Statins? Am I already?" And I was only 45 at the time.
Mhm.
So I think I would love for you to just share a little bit what are some of the important markers to look at when somebody
Yeah.
says, "Okay, I want to start with blood."
Yeah, a lipid panel is a good thing to start with, but not focusing on the specific markers on their own. You want to look at a lipid panel in the context of particles also. So what really imparts risk is not the total amount of cholesterol, which is what we get with a lipid panel, but it's how much they're divided into particles. The more they're divided into particles, then the higher risk you have. And that's detected by something called ApoB. ApoB is the protein that's on the outside of the LDL particles, and every LDL has one ApoB on it. So that's a really accurate assessment of all of the LDL, of all of our atherosclerotic risk. So it's less about total amount of cholesterol and more about particles. Now, this goes into the physiology of how we transport cholesterol. You can have LDL particles that are really small and really dense, and they're like bullets that will penetrate the lining of the artery and more likely to cause damage, more likely to get inflamed. And then you can also have, on the other side of the spectrum, larger, less dense, more fluffy LDLs that are like beach balls, and they will bounce around the inside of the artery and not cause any damage. If you just look at the LDL number by itself, there's no way to differentiate that, and everybody just gets the blanket approach of, okay, you got high cholesterol, you need to lower it. When in reality, if you have a lot of fluffy LDLs, you don't really need it to be lowered, and it won't cause a lot of inflammation. So there's an easy way to figure that out. You just test ApoB and you measure LDL to ApoB ratio. Two very basic tests. That ratio tells you, and if there's a cut, the cutoff is about 1.2. If you're lower than 1.2, then you end up having more of the small dense LDL. If you're higher than 1.2, then you tend to have more of the fluffier LDLs. So that's one easy differentiating factor. All right. And then you can look also further into that lipid profile, look at, say, triglycerides to HDLs. That can tell you about your risk of, or give you an idea of your energy metabolism. Do you have a risk for insulin resistance, things like that? You can look at your total cholesterol to HDL ratio. That can look at the ability of your HDLs to remove cholesterol that might be deposited by your LDLs. So those are some basic things that you can look at. And then there's the genetic test that everybody should be getting now is the lipoprotein a test. And that looks at if those LDLs have a specific protein that makes them more prone to causing plaque, makes them stickier and more prone to causing blood clots. So if you have a high amount of that, oftentimes it's associated with familial heart disease or early heart attacks. And that's one of those things you want to get detected early. Low amounts of it mean then you're okay. So those are some ways to interpret some basic tests. And when we want to look at further markers that look at other layers of what happens in plaque, we want to look at inflammatory markers. How is the system being stimulated, the immune system? What kind of inflammation is present? The inflammatory marker that's got the most data and is most globally used is called high sensitivity C-reactive protein. This is something that's made by the liver. It's in response to general inflammation. It could even be in response to infection, stress, surgery, trauma. So it's a great indicator of activation of your system and your immune system, but it's very generalized. So we can look at other tests that zero in on the vascular anatomy a little bit more. So that would be something called Plaque, PLAC, also known as LPPLA2. So this goes by both of those terms. And this is an enzyme that's in the arterial wall that can activate LDLs, make them more inflamed. All right. And then taking that one step further, we can actually measure the amount of inflamed LDL, and that's called oxidized LDL. So those two will go hand in hand and will indicate the amount of activation of inflammatory compounds in the arterial wall. Oxidized LDL tends to be concentrated into plaque up to 70 times more than what we detect in the blood. So if you see it in the blood, it means you definitely have high amounts of it, and it's collected in plaque. There's also another marker called myeloperoxidase, MPO, and this is an enzyme that's released by white blood cells. It's also in response to certain, can be infections or certain trauma, but in particular, it's a little more localized to the vascular wall. So when we see elevations in MPO, it can be an indicator of early inflammation in the vascular wall too. So these are just some of the more specific inflammatory tests that I like to look at that give me an idea of what's going on from a vascular standpoint too, because that's important as a contributor to look at whether somebody needs to get treatment for their LDLs. A high LDL with no inflammatory markers, maybe we don't have to be as aggressive. High LDLs with inflammation, yes, then we need to be aggressive, start some medication, and then look at imaging.
So useful. So you did talk about the basics in terms of the HDL, LDL, and triglycerides, but you're looking at ratios, the ApoB to LDL,
Hmm.
APL to ApoB, triglycerides to
Yeah.
HDL ratio, and total to HDL. Like these are just more detective work that you can do with a
Hmm.
very basic, non-expensive panel.
Yeah.
And then if those numbers don't look really good, you just take it next level and you do some of the LP little a, which I think LP
Hmm.
little a and ApoB should be in the basics, right? I mean,
Yeah, they should be.
and then the inflammation markers, the
Yeah.
HSCRP, the plaque, and the oxy-LDL, and the MPO. And one
Hmm.
thing that what happened when I went to go get my MPO
Yeah.
was that they gave me I think it was an immune
Yeah.
marker. It wasn't a cardiovascular marker. So there's two MPOs, you guys, warning. Make sure you get the correct MPO,
Hmm.
right?
Yeah. Yeah, a little more specific to the myeloperoxidase is also looked at as again because it is released by the neutrophils. It can be activated by the immune system from other avenues, and so it may be looked at from a autoimmune standpoint or a rheumatologic standpoint. And so that's a different test, though.
I want to just quickly go over the cholesterol number because this is what we're so stuck on, including me,
Yeah.
number on a scale. You just can't get over it. And I've heard that there's the ideal cholesterol is somewhere between 220 and 240, whereas
Hmm.
cardiologists like it to be under 200.
Yeah. Yeah, I think that that's relying on a specific marker, one number. You can't really rely on one number. I mean, there's no sweet spot really. It's what is the composition of of those lipids?
Mhm.
Because a person that has a lot of lipid that's not in little particles, they could sit much higher. And I don't think that there's not really any one magic number. It's really about context. It's about
Yeah, I
perspective,
think
the
you're
individual.
good answer. Good answer. And I can't keep going. Oh, back. I've got 300 total. And I'm like floored, going, what
Hmm.
in the world? But yet, you think that's where you're driving deeper. Okay, is there inflammation here? What's going on? Are the arteries actually clogged? Because that
Yeah.
number is just a number. And I'm back in my head, I'm like, I don't know. I think I'm doing all the right things, but I don't want to be one of those weirdo cases with
Hmm.
hyperfamiliar cholesterol,lemia or something.
Sure.
Maybe talk a little bit about that before I let you go, 'cause then we'll have a quick rapid fire. But I want
All
to
right.
hear about familiar hypercholesterolemia and what we need to know about that.
Yeah, this is a population of people that does not metabolize LDL and cholesterol the same way. They end up having higher amounts and depends on the genetic makeup. And this is why you want to test people some earlier, because if you have familial history, then it could be LP little a, it could be familial hyperlipidemia. And it could be mixed. It could be isolated to LDLs. It could be with triglycerides. But the metabolism is off. It's not functioning properly, and they will put more of the cholesterol into their blood. The liver will make more of it gets dumped into the blood, and then there may be a problem with the body being able to use it because what's inside the LDL particle is composed of cholesterol, and then it's also composed of triglycerides. Those are two different compounds. And the way the body uses them is differently also. One, they're both used for many things. Triglycerides tend to be fuel. Cholesterol tends to be precursors for many different things. And that's just a limited view of it. They do much more. But when the system is overloaded and people have too much of it, it's like putting too much fuel into your furnace. It will overload it, it will burn too hot and cause problems. Causes the mitochondria to not be able to function appropriately. You get more free radicals, and it causes many problems in many different systems. Heart disease being one of them. The difference is that what are those HDLs? What are they doing from a lifestyle standpoint? Sometimes people with elevated hypercholesterolemia that's genetic still manage to maintain good balance because they also preserve the ability for the HDLs to remove it. Unfortunately, some people don't have that, or it just overwhelms that reverse cholesterol transport, and then they develop more of the plaque.
So unfair genetics sometimes. It's even when you do all the right things, you're just like this
Hmm.
hyper responder to all these things. And I think we need to let you go because I have so many more questions, and I really
Hmm.
do want to dive in deeper about what can we do. I mean, we always
Sure.
mentioned HRT and whatever can bring
Hmm.
nitric oxide, but I really want to go into nitty gritty about some of the action steps that we can take in order to lower cholesterol or reverse plaque or protect our heart. So if you don't mind, I would love to have you on for a part two. Is that okay?
Oh, that'd be great. I'd love it.
Great. So let's do then the rapid fire. And
Okay.
because we can go through this and you can then explain in the next part too, because I know it'll be hard to say a short answer because it's probably nuanced and it depends.
Yeah.
But you're a well-respected cardiologist and you look really beyond the standard of care. So with this rapid fire, I want a really quick impression of where you stand.
Yes.
You ready?
I'm ready.
Great. Okay. Keto, the ketogenic diet for heart health, depends or dangerous?
Depends. Yeah.
Saturated fat, villain or scapegoat?
It's been more villainized. I think villainized, meaning it's a scapegoat. Yes. Does that make sense? Yeah. Let me rephrase that. Yes. It's a scapegoat. The studies never really supported saturated fat as being bad, but there are populations that need to watch out.
Statins.
Statins, I feel like they are both overprescribed and are a life-saving medication.
Red yeast rice.
I think there's more of a placebo effect on red yeast rice, especially in the contemporary era where the active ingredient is much reduced.
Fish oil.
Fish oil is very important depending on where you live and your diet. In the United States, we have a deficiency of fish oil consumption, so it's much more important. I think internationally in Mediterranean diets, you get some, but really be cognizant of it.
Stress or sugar, which damages arteries faster?
I think that sugar will damage the arteries faster, but stress is a very underappreciated risk factor and really needs to be addressed.
Biggest cardiovascular myth that women believe?
If they are told that they're not having, if their chest pain is not, well, if their arteries are clear, then they don't have disease. That's not accurate, and that's really misrepresenting the potential, the diversity of problems that women have.
One heart test you'd never skip?
That would be the CAT scan with contrast, the Clearly test.
One supplement you'd never blindly recommend?
The one that most cholesterol lowering medications, I think that even as a supplement, there are some effective ones, but it's more about knowing what you're treating and understanding what the lipid dynamics are instead of just blindly taking something to lower it.
Cool. We're going to dive into this in part two. and for now, I'm going to let you go, but you are open to seeing new patients, are you?
Yeah, at my Boulder Longevity Institute, and I'm seeing new patients. We see people internationally as well as across all of the United States. We're excited to take on new patients and to help people out.
Excellent. I can highly recommend you myself.
Thank you.
So I will have a link to that in the show notes and how to reach out to you. You've also on Instagram and Facebook, LinkedIn, YouTube, and we're learning more and more from you. And you've got an upcoming vascular medicine and cardiology health course for practitioners. What's that about?
Yeah, there's a course that I'm putting together that puts together the complexity of atherosclerosis. And this will be focused specifically on atherosclerosis, but it weaves in everything that we talked about, and including other dynamics. It's looking at all of the factors, the pathways that lead into atherosclerosis, because it's multi-layered, as well as treatment options, and talks about some newer treatment modalities, some of the testing, and what we can actually do to try and stabilize and maybe even reverse plaque once we detect it.
Sign me up. I'm not a practitioner though, but is it only for people must have some degrees, or could it be anybody who's in this health and wellness world?
I think it could be anybody. Yeah, I think it'll be open access. We're in the final phases of completing it, but there's that. And then you can always catch me speaking at some conferences. I'll be at an upcoming one called CALM. New BioAge puts that one out. And there'll be some other speaking coming up. I usually speak at Vibrant sometimes, and they have a great test panel that I really love using that gives really nitty-gritty details too. Yeah, you can find me out there.
Excellent. Oh, I'm super excited. I thank you so much for your time, your knowledge, and taking a deeper dive than the average person here in terms of our heart health.
Happy to do it. Thank you. I love podcasts and educating.
Yeah. And thank you so much for everyone who's listened to the end and obviously concerned about your heart health. I hope you learned something new. We deeply appreciate your time. Share this episode with somebody you love who may be concerned. And Dr. Husain, is there anything you'd like to share before I let you go?
No, I think this is perfect. This was, we touched on all the really important topics. So thank you.
Oh, wonderful. Okay. We'll see you next time. And everyone else, we see you have a good day, good night, good morning, wherever you're at.